Welcome to Heart Nurses, brought to you by the Preventive Cardiovascular Nurses Association. PCNA's mission is to promote nurses as leaders in cardiovascular disease prevention and management.
In today's episode, we're going to be discussing cardiovascular disease in cancer patients. And I'd really like to thank our two guests, Kerry Skurka and Janet Celli, for being with us today. Kerry, could you please introduce yourself, and then we'll have Janet introduce herself.
Hi, my name is Kerry Skurka, and I am a cardio-oncology nurse. I have been a cardiac and an oncology nurse for a long time in my history of nursing professions. However, in 2016, I started this brand new subspecialty and became a cardio-oncology nurse navigator.
So, Janet, could you introduce yourself to our audience, please?
Yes, my name is Janet Celli, and I am a critical care nurse out of Advent Health in Orlando, and I started my career back in 1986 in Boston, Massachusetts, with a couple of years of experience in oncology initially, and then transferred over to cardiology for the remaining several years. In 2019, I was blessed to be offered a job that actually linked both of the careers that I had been involved in my nursing career in cardio-oncology. I had not heard of cardio-oncology prior to that, but it has been a tremendous blessing to be able to help with preventative medicine with patients in the field that we're in.
Well, our audience can probably tell already that we have a lot of great talent on the podcast today. So let's go ahead and get started. And Kerry, I'm wondering if you could help us understand the basics of what do we really mean when we say the words cardio-oncology?
Well, cardio-oncology is a new subspecialty. Actually, the American College of Cardiology gave it its own section as cardio-oncology in 2016, which is when I started in the field. And basically, it's going to be one of the largest and is now the fastest growing subspecialty that you're going to see. Because what it is a field where we look at the cardiovascular side effects or disease that can affect cancer patients as they go through oncology treatment. And we look at them from the beginning before they go into it, trying to make sure that they're managing their comorbidities the best they can before they start their treatment. Then we try and mitigate any side effects that might happen through the course of their oncology treatment. And then in survivorship, we help them to have the best quality of life, also trying to help them manage any side effects or long-term effects that might have occurred from cancer.
Janet, I'm wondering if you might be able to lead us through a little bit of history when it comes to the treatment for cancer patients.
Yes, absolutely. As many of you may know, anthracyclines have been around for quite some time. In the 1960s, they originated in Europe, in Italy, in fact, and have been very successful in treating childhood leukemias and solid tumors, lung, GI, and breast cancers. And in the late 1980s, early 1990s, we started to see cancer survivors present to cardiologists with cardiovascular symptoms such as congestive heart failure. So although these are very successful treatments with cancers, we started to realize in the early 1990s that we had to actually monitor patients for the long-term effects of congestive heart failure and cardiovascular symptoms, because our mission is to make sure we're successfully allowing our patients to complete the therapy, but we don't want them to succumb to potential cardiovascular side effects from the chemo.
So based on what you've just described, I'd like us to, if we may, dive just a little bit deeper into the chronicity of many cancers today. And I think we all recognize that thanks to the changes that have happened in cancer treatments, that a lot of our cancer patients actually have much longer lifespans than they did 30 or 50 years ago. And what are those cardiovascular complications or implications, I guess I should say, of that kind of treatment? Kerry, perhaps you could start.
Well, first, I think I'll just talk a little bit about the chronicity of cancer because, we first started with radiation therapy back in the 1920s. And then we went to chemotherapy. And from that, and that was basically to kill cancer cells. And then from the next piece that happened, we started research and development, got us to the place where there was targeted therapy, which was directed specifically at cancer cells. And then from there, we have moved to the place of immunotherapy, where we are recruiting a patient's own immune system to kill cancer cells. And as I say, kill cancer cells, we have a wonderful body. And while we may say, try and focus on cancer cells, the other place that we end up having issues with is the side effects from them targeting cancer cells. And that ends up bringing us to a lot of cardiovascular effects, because the two cardiovascular system and the cancers that occur often have the same cells, and therefore you end up with several different kinds of cardiovascular side effects. Probably the one, as Janet alluded to, related to anthracyclines, or the red devil, as if a lot of times if a patient doesn't remember, you just say, did you get a red drug when you were going, because it is red? And it did cause decreased cardiac function, like heart failure. And that was probably one of the first ones. Then we also see anthracyclines. They can also cause arrhythmias. There's other ones that can cause hypertension is a big one. They can also cause valvular disease. So there's a lot of them that can happen from that. I think, Janet, you have a recent event with a patient of yours who was getting anthracyclines. Would you like to share about that? I thought that was a good story.
Yes, if I can supplement what Kerry also said with the anthracycline, she mentioned adriamycin, and receiving a larger dose of adriamycin can also affect an outcome. If somebody's received more than 450 milligrams per meter square, that would be a red flag for potentially putting somebody at high risk for cardiovascular side effects. And also anthracyclines paired with HER2 therapies, Herceptin and Perjeta, are also drugs that we would look at if somebody is getting anthracyclines and Herceptin and Perjeta. Those would actually put people in a higher risk category for cardiac side effects. And as Kerry mentioned, if I can just bring into light, what we do in our program is echocardiograms, but we do, instead of a 2D echocardiogram, we do a 3D with GLS strain echo. And what that would give us is a specific number instead of a range. For example, in a traditional 2D echocardiogram, you would get a range possibly of 50 to 55% or 55 to 60% for ejection fraction. If we look at a 3D echo, it would give us a specific number, and anything less than 53% would be a red flag for me for ejection fraction. And the other important factor for 3D strain is it gives us global longitudinal strain, which is something I also look at, and that's actually the strain on the myocardium. So if somebody has a negative inverse number that's less than 17, minus 17, in other words, if it's minus 16, that would be a red flag for me. And what Kerry was alluding to is I had a patient that just recently this past week had an EF of 56%, which is not unusual. A cardiologist would look at that and say that's perfectly normal. But we had a GLS on that patient that was below 17. It was actually minus 10. So that was a red flag for me. And that's the type of technology that we are thankful for to look at. Looking at echocardiograms, we can be preventative in catching long-term symptoms, cardiovascular symptoms, and really flag the oncologist and make sure that we make a cardiologist aware of that, because we want to make sure that patients successfully get through their therapies. We want to really kind of be preventative in making sure that the heart disease isn't something that we miss in the bigger picture.
Thank you both so much for that great information about cardio-oncology, a little bit of historical background on what cardio-oncology is, what we do, and how it might affect the cardiovascular system. We're going to take a real quick break, and we will be right back.
For more education, resources, and tools for your clinical practice, visit pcna.net. You'll find CE courses, patient handouts, and more, all free to access. Visit pcna.net.
We're back with Kerry Skurka and Janet Celli talking about cardio-oncology. And I'm wondering if we could dive just a little bit deeper into another kind of therapy, which most of us are familiar with, in addition to some of those chemotoxic, perhaps, agents that are being used. But what about radiation? And how does that affect the risk for cardiovascular disease or those cells? We've kind of alluded to that, but I'd love us to spend just a little bit of time on that. And Janet, would you like to take that question first?
Yeah, thank you, Geraldine. If we're looking at any type of radiation to the left side of the chest, it would be something that we want to be made aware of. Anything that's greater than 30 gray in the heart field itself can really cause or really put somebody in a higher risk for cardiovascular complications afterwards. So if you're talking about left-sided breast cancer or perhaps a tumor that's on the left side of the lung or anything that's affecting the left side of the chest, that's something we definitely want to be aware of and follow that patient long-term for any long-term effects, cardiovascular effects, whether it be acute coronary syndromes or atherosclerosis or thrombus. Those are definitely some of the things to be aware of, looking at that patient historically and making sure we follow up with them if they have any symptomatology that would warrant further evaluation.
I think I would also add to it that it is also the mediastinal area is also one that is involved. And so there you can see a lot of Hodgkin's patients tend to have mantle radiation, as well as Janet talked about the left side and breast cancer for sure, but you can have lung cancer also. And looking at mediastinal, you can also have esophageal cancer. Those are areas where radiation and as she alluded to, you can definitely have all of those side effects like she mentioned. I think I saw my first realization was when I was doing open heart and someone said, "Oh, I had breast cancer a long time ago." And so those are the types of side effects that we're trying to stop with cardio-oncology.
As we've learned today, cardio-oncology is quite a complex field, and there is definitely a lot to learn. Are there some resources that our listeners could access if they have questions about what's been discussed today? Perhaps, Kerry, you could start with some potential resources.
I think that you can, one of a really good resource for patients' education is the American College of Cardiology CardioSmart. They have a section about how cancer can affect your heart. And I think it's a resource that isn't seen very often because most cancer patients don't realize that this is something that can happen. And they have some great educational tools as well as ways that they can help themselves.
And if I can supplement what Kerry just mentioned, we as nurses, ICOS, the ICOS actually is a great format for Cardio-oncology Society, and it is an international group that every Thursday from 9 a.m. to 10 a.m. has great informational topics. And thanks to the pandemic, it's something that you can just sign on to and join ICOS and be part of journal clubs. It's a webinar format and really offers a great opportunity to see what's going on really around the world with benchmarking our care for patients and doing our very best to deliver excellent care and collaborate with nurses and doctors from, as I mentioned, all around the world.
I think also you can go to the cancer support community. They have good resources there for patients, as well as the Association for Cancer Community Centers. These would be other places that you might find some education for your patients.
Well, we certainly have learned a lot about cardio-oncology today in our first of 3 episodes. In our next episode, we'll be discussing additional side effects, arrhythmias, atherosclerosis, hypertension, and thromboemboli. We look forward to seeing you then. In the meantime, this is your host, Geraldine Warfield, and we will see you then.
Thank you.
Thank you for listening to Heart Nurses. We invite you to visit pcna.net for clinical resources, continuing education, and much more.